Good evening, everyone. I would like to give thanks to Dr. Sandeep Sir and organizing team to give opportunity for interacting with all of you. In first session, we have already discussed about the AGFR mutation, which is the most common mutation in targeted and driver mutation lung cancer. Now we will discuss about something ALK positive lung cancer in the first line management. These are general slides. We will skip it. And ALK gene regeneration lung adenocarcinoma was the second most common mutation found after the EGFR mutations. So it is a very important mutation after EGFR. And in the Indian study, approximately same incidence was found as in the ARD, approximately 1.6 to 11% patients of the non-small cell lung cancer adenocarcinoma have ALK mutations. And there is some characteristic feature in ALK mutation positive patients. One is that these patients are mostly younger patients. They are usually never smoker or light smokers, and they have some other characteristic features. So all these patients are usually young patients. So we have to treat them very cautiously because they need more therapy. They need more life than the older patients. And for the treatment, we have to some strategies because these are young patients. So we need less with good quality of life and long treatment. Second thing, these patients usually have more CNS metastasis, and even after on treatment, they have more CNS metastasis. So we need some target who can either prevent CNS metastasis or you can treat CNS metastasis very well. So from 2011, there are 5 ALK targeted TKIs available in India. First is the first generation TKI, crizotinib, which was approved in 2011. Second one is ceritinib and alectinib, which was approved in 2017. Next one is the brigatinib, approved in 2020, which was the second generation TKIs. And now third generation TKI, lorlatinib, is available, which was approved in the first line in 2021. And first, second, and third generations have more potency against the ALK according to their series, and they have more activities against mutations which was found in patients on the TKI, as well as more CNS activity or more CNS penetrations. So these are some randomized trial by which we have get approved in first line treatment. Crizotinib was approved on the basis of Profile 1014 trial, in which they did comparison with the standard chemotherapy. And what they found approximately 10.9 month progression-free survival versus 7 months in the chemotherapy arm. And according to this, they got first-line approval in the crizotinib arm. And second one is the ceritinib. According to Ascent trial, they have more progression-free survival, statistically significant. And in the Alex trial, in alectinib, they found very significant progression-free survival, 34.8 months in the alectinib, while 10.9 months in crizotinib arm in the progression-free survival. And this is the first trial in which they compare with the standard of care. Both first trial was on the chemotherapy, and next one is the ALTA-1 trial, in which they compare brigatinib with crizotinib, and they found 24-month progression-free survival versus 11-month progression-free survival. And if we discuss about the overall survival, then in Profile 1014 trial, there was after follow-up of approximately 46 months, the overall survival was not reached for the crizotinib, while approximately 47.5 months for chemotherapy arm. While if we discuss for the ceritinib in Ascent-4 trial, there is overall survival benefit still not reached and not statistically significant. If we discuss for the alectinib in Alex trial, overall survival was still immature, and after the end of 5 years, 60 months, there was approximately 65% survival in the alectinib arm, while in the approximately 45% survival in the crizotinib arm, and there is hazard ratio is approximately 6-7%. And according to these trials, what they found that there is approximately in all patients there are more CNS metastasis, or there are more CNS relapse. So in ALK positive patients who are generally young, non-smoker, and there are approximately 20 to 40% patients of untreated ALK patients has CNS metastasis at the time of diagnosis, so they have poor prognosis. So we need something new that can overcome these resistance, that who can overcome these type of CNS metastasis. And now the third generation TKI is available, lorlatinib, which was designed for especially metastatic brain cancer and acquired against resistance to LTKI. And it is more effective for CNS. So Crown study was designed for this, and in Crown study, what they took new patients of stage 3 or 4 ALK positive non-small cell cancer with either asymptomatic treated or untreated CNS metastases were permitted with one or more extracranial measurable targets, and they randomized in either lorlatinib or crizotinib, and no crossover was allowed in this trial. And primary endpoint was progression-free survival, while the secondary endpoint was progression-free survival by investigators, overall survival, or intracranial overall response rate, or intracranial time to progression. And basic characteristic was approximately same demography in both arms. And in this, what they found that at the end of 37.6 month median follow-up of lorlatinib arm was superior to the crizotinib arm. After the 36 month, approximately 63% patients has without progression in lorlatinib arm, while 18.9% patients has progression-free survival without progression-free survival in crizotinib arm. So there is statistically significant hazard ratio 0.27, which was very statistically significant in the favor of lorlatinib. And the confirmed overall survival by blinded investigator center team is 77% versus 58%. And the median duration of response was still not reached for the lorlatinib versus 9.6 months for crizotinib arm. And if we see according to subgroup, then approximately all subgroup have better benefit in the lorlatinib, especially age, gender, sex. So all favors to the lorlatinib arm. If we discuss in patients with or without brain metastasis, what they found, patients with the baseline brain metastasis, lorlatinib is still better, and there is a very good response rate. Progression-free survival of 7.2 months versus not reached in the lorlatinib arm, while without brain metastasis 11.1 and not reached in the lorlatinib arm. And in intracranial progression, which was still longer in lorlatinib arm, and what they found that at the end of 3 years, 36 months, approximately 92.3% patients has no intracranial progression in lorlatinib arm, while in 37.7% patients has no progression in crizotinib arm. And one point is to be noted that at the end of 2 months, there was 93.4% patients, while at the end of the third year, 92.3 months. It means their response is durable, and there is no safety profile difference in during these durations. So blinded assessment intracranial time to progression in patient with baseline brain metastasis is still better for lorlatinib arm. After the end of 6 months, 73% patients had good response with lorlatinib arm, while none patient in crizotinib arm, and the hazard ratio is 0.1, which was very good. I think it is a wonderful hazard ratio for patients who have brain metastasis. And patients without baseline, there is still a very good hazard ratio, approximately 0.02, and out of 112 patients, only 1% has baseline brain metastasis intracranial progression in lorlatinib arm, which is very significant. So in summary, lorlatinib is a very good drug, especially in this brain metastasis, and the confirmed overall response rate was 77% versus 58 months, while median duration of response was not reached versus 9.6 months, and patients with any brain metastasis baseline 24 versus 7, while median duration of response was not reached versus 9.4, and patient at least one measurable baseline response was 10.2 versus not reached in lorlatinib arm. And if we discuss about adverse event, most of adverse events of lorlatinib was manageable, and only 7.4% patient has discontinued due to AEs in lorlatinib arm, while 14% patient in crizotinib arm discontinues. In lorlatinib, most common adverse event was hyperlipidemia, hypertension, as well as some CNS events. So sometimes patients on lorlatinib has some type of forgetfulness, difficulty in day-to-day activities. So we have to differentiate these side effects with the progression of CNS progression. So, and if patient has these type of symptoms, so we can manage very well. We can discontinue lorlatinib for some time, and these side effects are dose dependent. So we can restart with the lower dose with the lorlatinib. And this show the side effects profile, and edema, hypertension, and hypertriglycemia are more common in lorlatinib arm, while crizotinib has more vision disorders, while more liver dysfunction and more fatigue than lorlatinib arm. So in summary, crown trial for lorlatinib at the 18-month as well as 36-month, which is a long follow-up, had still a good response, as well as there is no safety profile difference at the end of 36 months. And according to NCCN guideline, if patient has ALK positive non-small lung cancer, then alectinib, brigatinib, or lorlatinib or both are preferred drug, while ceritinib and crizotinib has other recommended drug. If we have started chemotherapy before the report of ALK positive, then we can complete the chemotherapy, including the maintenance. Then we can start TKI. And there are some meta-analysis which shows that the lorlatinib in the first line treatment, patient has a better than the other drugs. Although these are comparison with the various trials, so we can not say that these are good if we need head-to-head comparison between alectinib and lorlatinib. But according to these meta-analysis, lorlatinib has an effective first-line treatment for ALK positive non-small lung cancer when compared to crizotinib as well as the next generation TKIs. If they compare these trials, then lorlatinib has approximately favorable effect in all progression-free survival, alectinib and brigatinib and ceritinib. And overall survival are still immature in most of trials, even for this crown trial as well as the trials. So we cannot comment upon the overall survival. But according to this meta-analysis, most of overall response rate favors to the lorlatinib, but we have still to wait to comment on the overall survival. And this is another review which was published about comparison of lorlatinib with another second-line ALK inhibitor TKIs. And in this, they found that the lorlatinib is slightly better than these TKIs. And this is the subgroup analysis. In this, all favors lorlatinib. One thing is important, that in Asian population, lorlatinib is not favored. Alectinib is slightly more favored. This is point to be noted. While in other approximately all where the lorlatinib is more favored than the alectinib. And in smoker also, alectinib is slightly, although not statistically significant, favored than the lorlatinib arm. And this was a ranking which was given by this meta-analysis. This is not also a. This is given only by one author, and he ranks in first line, lorlatinib in first rank, while alectinib and brigatinib in second or third rank. So, conclusion of this network meta-analysis is that lorlatinib significantly improves progression-free survival than brigatinib and alectinib in hazardness of 0.7 and 0.59 respectively, and there is no significant difference found among OS as well as other adverse event analysis. And among these all second and third generation TKIs, probability to reach the best overall confirmed response rate was approximately 48, and intracranial confirmation was 44% for the lorlatinib arm. And in terms of progression-free survival, the results indicate that the lorlatinib was best treatment choice for ALK inhibitors first lines. And this is a comparison. This was given according to if we are giving either best drug in first line or we can give sequentially. So there is many debates, but we have to give either first line ceritinib or alectinib. Then if there is resistance, then we can give lorlatinib, or we can apparently start lorlatinib. There is various debate, but some says that we have to give best drug in the first line. So most of patients got benefit of the lorlatinib. So in conclusion, that the lorlatinib even after 18 months as well as 36 months has a better progression-free survival then crizotinib, and 3-year rate is 33.5 versus 18.9% for the crizotinib. And the time to intracranial progression was longer with the lorlatinib than the crizotinib. These efficacy benefit with the lorlatinib compared with the crizotinib were observed not only in patients with the baseline brain metastasis, also in patients without brain metastasis. It means it treat brain metastasis as well as also prevent from the brain metastasis in patients who does not have brain metastasis. And there is no new safety signals was observed in longer follow-up. And these updated long-term data from the Crown confirm that the efficacy of lorlatinib versus crizotinib is better than the other TKIs. So we can use lorlatinib as a first line. Thank you very much, sir.